Today's subject is pre and post-op care. This is very, very important. You might think that surgery is all about what you do in the operating room, and that is true. You do need to know what you're doing in the operating room. But the most important thing, and what makes a good surgeon a great surgeon, is the pre and post-operative evaluation. That's the hard part. And you, no matter what specialty you go into, you have to determine whether your patient is a candidate for surgery. Because technically you can do surgery in the operating room, but you have to make sure that you're being safe. And I will use that word over and over, safety. It is your goal to always be safe. Pre-operative assessment. Now this is very important that you realize we're talking about elective surgery. We're not talking about emergent surgery, because emergent surgery is emergent, meaning it doesn't really matter how the patient is because you have to do surgery. So we're talking elective surgery, general anesthesia. So we're talking about elective surgery and general anesthesia. We're not talking about local anesthesia. We're not talking about twilight sleep. We're not talking about sedation. We're talking about general anesthesia. So what we're going to talk about are the systems you have to evaluate before elective general anesthesia to make sure you're being what? Safe. So first we talk about the heart. Basically, if you remember three things for the test and life, you will be safe. One of the risk factors for general anesthesia with respect to the heart is number one, congestive heart failure. Guys, if someone's in congestive heart failure and you put them under general anesthesia, they have a high likelihood of dying. So congestive heart failure is number one of the reasons you do not want to do general anesthesia. A second reason is a new arrhythmia. Now you might say, well, what if they have chronic atrial fibrillation? No, that's okay. But if they have a new arrhythmia, like PVCs, or runs of VTAC, or A-flutter, which is new, or atrial fibrillation, which is new, or anything that's new, you can't put that patient to sleep until that gets sorted out. One of the things that I'm going to tell you now, you must always remember for the test and life. Generally speaking, all general anesthetics do two things to the heart. Number one, they decrease inotropy, the contraction of the heart. And number two, they increase ectopy. Let's repeat that. Generally speaking, all general anesthetics do two things to the heart. They decrease inotropy and increase ectopy. So is that a good or bad thing? That's a bad thing. So you have to realize that general anesthesia in of itself, the agents that they give, they have risk factors. So in summary, for heart, for elective general surgical procedures, for general anesthesia, those three things, congestive heart failure, new arrhythmia, and myocardial infarction within 6 months, those are contraindications for elective general anesthesia. All right, now let's go to the second system, your lungs, pulmonary. Now, remember that the lungs are a conduit to get the gas that you're breathing in into your bloodstream to anesthetize you. So if you have a pulmonary problem, it will affect how you do under general anesthesia. And by far, the #1 disease we deal with is COPD, chronic obstructive pulmonary disease, emphysema. And you know how you get this, by smoking. So all you young people, do not smoke cigarettes, and I hope your patients don't smoke cigarettes, because it is really, really bad for you. Now, once again, you might say, well, if a patient has an acute appendicitis and you have to operate on them and they've got COPD, well, you got to do it. That's emergent. But if it's elective, general anesthesia is very risky. Now, one of the things that you see in evaluating the pulmonary patient is increased PCO2. They live at a higher CO2 level than people who don't smoke. You know that. And test question, life question, if you had to pick one pulmonary function test, which is the most significant, if you had to pick one, and you have to memorize this, it is the FEV1, forced expiratory volume in 1 second, FEV1. That tells you the most. Now, you know that smoking causes irreversible changes in the lungs. So if you stop smoking, let's say a month or 2 prior, and you got pulmonary therapy, would it help? Yeah, oh sure. But will it make you perfect? Nope. You will always have that significant risk. So remember, your lungs are an important part of being safe under general anesthesia. So now, let's go to the liver. Now, the liver is an important organ. It kind of cleans out everything in your system. And when you have liver disease, this also will affect how well you will do under general anesthesia. Now, you might say, well, what diseases is the most common for the liver? You might think hepatitis or hepatoma or all those, but it's quite commonly alcoholic liver disease. And that is the most common. And I'm sure you've seen a lot of patients with alcoholic liver disease. The way you evaluate a patient for elective general anesthesia with respect to their liver function are 5 things. And this is called the Child's classification, and it's the most common. It's the most common classification that I want you to know for the test and for life. And you look at 5 things. Number 1, ascites. Number 2, bilirubin. Number 3, coagulopathy. Number 4, albumin. And number 5, encephalopathy. Let me repeat those. Ascites, bilirubin, coagulopathy, albumin, and encephalopathy. My young colleagues, if a patient has all of those being abnormal, that patient will have a very high likelihood of not surviving general anesthesia, irrespective of the operation. It's the general anesthesia. So always look at your liver function tests and the patient with respect to their liver competency. And this is the child's classification. Now, I will only mention to you, and it's not going to be on the test, and you don't need to know it unless you go into surgery or go into hepatology. There's another system besides the child system, and it's called the MELD, M-E-L-D, the MELD score. And just so you know, that looks at three things: bilirubin, creatinine, and coagulation. Bilirubin, creatinine, and coagulation. But for your purposes right now, the most common approach, both for the test and life, is the child classification. And as you know, you might ask me, can you improve a patient who is an alcoholic with significant liver disease? It's not easy. And usually all of those changes of alcoholic liver disease is irreversible. So, and you will see in your practice, you will see many patients who are alcoholics with significant liver disease. It's unfortunate, but you will see it. All right. So now we go into, we've already talked about heart. We talked about lungs. We talked about liver. Now we're going to talk about nutrition. Now I want to tell you something. When I was your age, we did not have one course in nutrition. We really didn't look at it as being terribly significant. I mean, yes, we knew that it was important to get calories and protein and fat and carbohydrates, but it really wasn't appreciated until later years. And now we realize that you are what you eat. And it's more than just having an adequate weight and having adequate calories, etc. Listen to me carefully. Test question and life question. If you are malnourished, that is an immune deficiency. That's so important. I'm going to say it again. If you are malnourished, that is an immune deficiency. And is immune deficiency a good or bad thing? It's a bad thing. It's a very bad thing. It is like being on steroids, like having cancer, being on immunosuppressive drugs. It's awful. And so therefore, if someone would ask you on the test or in life, what would be the optimal test to determine if someone was malnourished? The optimal test. It would be skin test energy. Skin test energy. Now, what that means is that, you know how sometimes you go to the allergist and they want to see if you're allergic to something, and they give you a little skin test. They inject a little something under your skin, and you respond to it if you're allergic to it. Well, if you are malnourished, and you are severely malnourished, and you have immune compromise, deficiency, you won't respond. You will be anergic, and that is a very bad thing. But we don't often, when we see a patient who we think is malnourished, we don't often do skin test energy because it's a lot of work and it can be a little bit cumbersome. So we look at simpler things. We look at weight loss. Guys, if you've lost 10 to 20% of weight relatively recently, that will be malnourished. If your albumin is low, or your pre-albumin is low, that is malnutrition. And your serum transferrin level, if you measure that, that's low. The point is it hard to determine whether or not you're malnourished? No. You generally have an idea of the patient. Bear with me, listen. Can an alcoholic be malnourished although they're fat? Yes, yes, yes. So don't just think that if someone has a lot of weight on them, that they can't be malnourished. Now, a very, very important point. Remember I told you that malnutrition causes an immune deficiency. And you know there are two types of immune processes. One is cell-mediated immunity, and the other is humoral immunity with antibodies, things like that. They're both important. But if I had to ask you a question, which do you think is more important? They're both important. But which do you think is more important? Cell-mediated immunity or humoral immunity? Guys, it is cell-mediated immunity. Now, remember we talked about that the ultimate test for malnutrition, which we don't do routinely, is skin test anergy. And as you recall, skin test anergy, when you're anergic, caused by malnutrition, that is a cell-mediated immunity process. Now let's review a little bit of immunology real simply. You remember that there are basically two types of immunity: cell-mediated immunity and humoral immunity. Humoral immunity is the antibodies things, okay? They're both important. You need both. But if you had to choose between the two, which do you think is most important? Without question, cell-mediated immunity. Guys, I want to tell you, when I have had patients who have been immunodeficient based on cell-mediated immunity for other reasons, they do not do well. In general, they do not do well. So what's my point? My point is I want you to understand that malnutrition in of itself is really a bad thing. And when you associate it with general anesthesia, it's even worse. People die because of malnutrition, and the primary reason is immunodeficiency. So what's my point here? My point is, when you are in your residency and your practice, and the dietitians and the nutritionists talk to you and they say, "Doctor, can I advise you a little bit?" You put down everything you are doing and you say, "Absolutely, and thank you, and tell me," because they know more about nutrition than you will ever know. So always remember this. It's very important to listen to the dietitians, listen to the nutritionists. Very important. Now, let's say someone is malnourished and you want to tune up a little bit preoperatively. You actually can. A ballpark week of giving nutritional support, and in general, test question and life question, enteral, meaning through the GI tract, is always better than parenteral in the vein. So always, if you have a choice between enteral and parenteral test question, always enteral, do it. A week or 10 days of pre-operative nutrition makes a difference. It really does make a difference. So just remember that nutrition is important, really important. So now we final system, risk factor for general anesthesia. We already talked about, remember, heart, lungs, liver, nutrition. Now we talk about metabolic. Now this is just common sense. If someone is in diabetic ketoacidosis, you're not going to take them for general anesthesia actively. Of course not. Of course not. You want to improve that. And you could improve that relatively rapidly, even in a situation which is an emergent situation. If they're dehydrated, are you going to take them to surgery dehydrated? No. If their electrolytes are all out of whack, are you going to try to correct them? Yes. So the point is, you want someone to be reasonably metabolically stable. They don't have to be perfect, but they have to be reasonably stable. So when you think about a patient that you are going to take to surgery electively under general anesthesia, think about and go through in your brain those 5 things: heart, lungs, liver, nutrition, and metabolic. And just make sure that that patient is okay in all of those systems. Because if you take a patient for elective anesthesia under general and they have those risk factors, that patient is going to be in trouble.